So good evening, everyone. Welcome to everyone who's joining us at Keble College, the University of Oxford, and those who are joining us online. My name is Sherine El-Taraboulsi McCarthy. I'm a visiting fellow at Keble College. I'm also the director of NatCen International, which is a new cross-institutional program at the National Center for Social Research. NatCen International seeks to empower societies all over the world to influence and shape policy and practice and really address that gap within the international system. We also try to bridge the gap between international thinking and issues and social and local priorities and practices. We have 6 core work streams, cross-cutting core work streams, of which global health and particularly global health equities is a core focus. So I'm delighted to welcome you all today to this session, which is a collaboration between Keble College and NatCen International. Now let me, before I introduce our very distinguished set of panelists, allow me to contextualize this discussion a little bit and explain why it's important for us to talk about the politics of global solidarity in the age of COVID today. And I would ask you to think back to January 2020, when the Director General of the World Health Organization, Dr. Tedros, called on countries and states to collaborate in solidarity with one another and respond to a global health emergency, which was the pandemic, COVID-19 pandemic. And since then, there have been instances of success in terms of international cooperation. One of them is the establishment of the COVID-19 Response Fund by the WHO. Since November 2021, the COVID Response Fund has over $257 million taken in the form of pledges and donations from donors, states, and philanthropists all over the world. So it is an instance of some form of international solidarity and cooperation and a belief in the need for concerted effort to respond to the pandemic. Still, that amount is a far cry from the 1.9 billion that the WHO had originally called for and called on all nations, states, and philanthropists to contribute to. There's also a parallel story to this and a parallel narrative that is very unsettling and very worrying, which is the fact that only 8% of Africans have managed to receive full vaccination to date. And that is happening as Western or high-income countries have a lot more booster vaccines going into people's arms than first doses going in low and middle-income countries. And so you've got a parallel story that does not show any levels of acceptable cooperation or solidarity in the pandemic response. Now, the reason why we're meeting today is because we want to have a hard and very frank and honest look at what the politics of global solidarity mean. What is the truth behind that global solidarity? And more recently talks about a global reset in light of the COP26 conference. So what do we really mean by this term? And what does it mean in terms of actual collaboration between states and nations? What does it mean in terms of collaboration between multilaterals and other organizations? And to what extent does it actually represent and speak to the priorities that countries are experiencing, societies are experiencing at the local level? And so 3 questions I would like us to focus on today. The first one is, to what extent has the global response been successful? Is there anything, if we reflect backwards on what happened since 2020, what are the successes? What are the reflections on the global response to the pandemic? The second question is about the systemic opportunities and challenges. What have we learned in terms of systemic blockages, both within the multilateral system itself, between multilateral organizations, international organizations, and states in responding to the pandemic? And what can be done about those blockages? How can we expand the opportunities? And then the last question is, what does the future hold? Now reflecting on that experience in the last couple of years, but also a wealth of thinking and analysis on global solidarity and international cooperation. what does the future hold for international cooperation in light of the pandemic response? Is this going to be a turning point in terms of how the international system deals with similar shocks? Or is it going to be business as usual? It's just one more crisis like every other humanitarian crisis that has taken place all over the world? Is it just one more thing and we go back to business as usual? Or should we really look at that moment as a turning point for how we think and approach a collaboration within the international system and across the international system? Now, joining me to respond and address all of these questions today is a very distinguished panel of people who I think are very much disruptors in their field and in terms of their thinking, and are also very brave in addressing a lot of those issues that are related to equity and related to international engagement in low and middle income countries. Well, first, William Chamele, who is the Global Protection Cluster Coordinator. And the GPC, for those of you who don't know what it is basically a network of UN agencies, international organizations that do and focus on protection work in humanitarian crises. And that includes countries that are affected by armed conflict, but also countries that are affected by natural disasters and environmental issues. William is very much somebody that I talk to and I engage with in order to address a lot of the issues related to localization, a lot of the issues related to equity. And I really think that he's provided a lot of leadership and a lot of thinking in that space. Joining us as well is Tammam Aloudat, who is the Managing Director of the Global Health Policy Center at the Graduate Institute in Geneva. Tammam has first-hand experience of working and operating in conflict-affected contexts and humanitarian crises. He's a Syrian doctor, and he's experienced this conversation from both sides, as a practitioner, as somebody who's had that first engagement, the urgency and the need to act in humanitarian crisis, but also someone who sits at the Graduate Institute in Geneva and who's actually been thinking and tackling a lot of these issues from a policy and a theoretical perspective. And of course, my very own colleague, Dr. Priya Gombeta, who is the director of the global of the Health Policy Center at the National Center for Social Research, and who's been actively engaging with me on thinking about how to develop a disruptive agenda on global health policy that takes stock of what has happened the last couple of years and really puts us on, generates new thinking in terms of how the international system can cope better and address better a lot of those challenges, which I think, and as I mentioned again in the introduction, are not new. And I strongly encourage you to think back to the World Humanitarian Summit, in 2016, and all the discussions that we've had about the grand bargain and localization and bridging the gap between the international and the local. Where has all of that gone in the pandemic response that we have witnessed to date? What does that mean going forward? So the way we're going to structure the session is that it's going to be a conversation. It's not a set of rehearsed presentations that each presenter or speaker is going to present. It is really a conversation. And I'm going to be asking them questions, engaging with them, and also probing them on some of their responses. And then towards the end, we'll open up for Q&A from all of you, as well as from those people who are joining us online. If you're joining us online and you've got a question, please just go ahead and type your question into the chat box, and then we will get to address it in the Q&A part of this session. So let me start off with the first part, or the first question, which is the reflection part, really looking back at the last couple of years and the pandemic response. And let me start off with Tammam. As someone who has experienced the urgency to respond in a humanitarian crisis, Tammam, what are your reflections? What did you think of the speed of the response to the pandemic? And what is your take on that? Over to you, Tammam.
Thank you very much, Sherine, and for Keble College and NatCen for making the opportunity for us to discuss. I think just to lay the ground for a little bit, most people won't be cognizant that this is not the first pandemic in a very long time. The discourse usually goes towards 1918 and the Spanish flu, which has claimed more victims than the First World War. Since then, there has been at least a few pandemics, most of which are influenza pandemics. The last one has been in 2009. Some of you remember the swine flu or the H5N1. Sorry, the H1N1. But before that, there has been a potential, an edge case of a pandemic in the H5N1, which spread among birds in Southeast Asia mostly. I was in Indonesia when, after the Indian Ocean tsunami, when the cases of H5N1 started becoming capable of jumping the species barrier, as the technical term goes, and create small clusters. And there was a fairly, and that was 2005, and there was a fairly swift response. The swift response was culling birds. That was my first time learning that term. As a non-English speaker, I still learn new words. And the culling of birds included killing all birds in affected areas in Indonesia and Aceh, where I was. And that included most people's domestic birds, their source of income. Not many were compensated for it. Of course, policy-wise, the whole, health policy circle in the West and abroad was buzzing with the possibility of a pandemic. But the actual action has been depriving people of their livelihood. And I think this is just to park it on the side, to keep in mind that a pandemic is not just a disease that causes infection and sickness and death. The response in 2000, so the concept of a pandemic is scary. And even though we think it wasn't fast, it was fairly fast. It was also fast in 2009. When a concern was expressed immediately with the first cases of H1N1. The problem then was the overreaction. Margaret Chan, the Director General of WHO at the time, and her team had mobilized fairly fast. And as luck would have it, the H1N1 turned out to not be a very virulent virus once it started sustainably transmitting among people. So the pandemic of 2009 wasn't as fatal, although it has claimed a large number of victims, but it was nothing like what we see today. So the accusation was of overreaction. The rapidity of response caused accusations of dramatization, of overreaction, and so on. Now, come to 2020, I think the response was massively rapid. If you were an inhabitant of China or of a Western country capable of taking a reaction, time is not the same wherever you live. That has always been the case. If you go to a hospital in almost any low resource setting, you'll realize that medical technology time is still running a few years or sometimes decades behind. But when it comes to this pandemic, the response was rapid. The realization that we have an infectious agent was very fast. Now, the delay in acknowledging the risk of an infectious agent is a couple of decades in the making, because the SARS was the signal that should have prepared us for this from 2003, or the MERS, the Middle East Respiratory Syndrome, from a few years behind. So it was over time for preparedness. The initial response was fast if you are in a rich country, and it's still not time yet if you are in a poor country, as the statistics of vaccination prove. And I think it is important because it's important to recognize how variable time is depending on where you are in the world and which background and which context you happen to be in. Because if anything, we are struggling with a sort of a discrepancy in narrative today. Most of those who or many at least, in places where it has been reactive and capable of containing the worst of the pandemic, if not all of it, feel that it was overdone, overreacted, it happened too fast, it went too far. I don't think, despite that the airwaves are dominated with voices from places where that kind of reaction took place, that we have the luxury anymore to ignore those who still have not seen the reaction, where it's overdue, too late, and where the influence and the effect of the pandemic, and by that I don't mean the virus only, but I mean the whole plethora of things that are caused by the pandemic, and those are very different from one place to the other, have been happening for 2 years with virtually no response. Technically, though, we have to acknowledge that, there's a vaccine that several billion doses have been given, let alone the misdistribution of those doses. This is not very often heard of, the development of a new vaccine and a massive manufacturing capacity as short of covering the world as it is, has happened in such a rapid space of time. Given that we still don't have an effective vaccine for tuberculosis or HIV, and that the vaccine of malaria after decades of work is still less than beautifully effective as the one for COVID is. So I guess my message is there has been the capacity, there has been the negligence that led us to need that capacity as we did it. And there's still the variation of response that is most emphasized if you are born outside a dominant, rich circle of the West, where ironically most people are unhappy with the response, or at least there are plenty of voices that are still unhappy with the response. Thank you.
Thank you, Tammam. I think you've made two very important points. The first point is about the time issue, the temporal aspect of the pandemic and its trajectory in some countries versus in others. And I remember I was in a panel discussion with the new Humanitarian a few months ago. And one of the questions I was asked was about the rate of the infection in Africa being so low. And I think that the response I gave back then, which I think will still hold true today, is again very much the temporal aspect has not been taken into account, and that we very much fall into the trap of looking at the pandemic from a Western perspective, through Western lenses, without taking into account a more holistic impact for the pandemic in a number of other countries, in low middle income countries, where we may not have seen the worst of the pandemic yet, or we may not have understood the full impact because the data is not available and governments are not as transparent and so on. And so I think you've made a very important point there. And then the second point is that the impact of the pandemic needs to be viewed holistically, not just through the effect that it has had on lives, but also the effect it has had on livelihoods, and even at another level, the level of frustration and disappointment that a lot of countries face and feel towards that lack of vaccination, the limited access to vaccines. And this is another thing that I would like William to actually respond to. William, what are your thoughts and what's your take on the pandemic response from where you sit at the Global Protection Cluster?
Sherine, thanks a lot for hosting this, and I think the value of having this discussion for us is equally the content of the discussion. But I hope with the convening capacity you have to attract the best minds and hearts of people in your circle to join the humanitarian sector. We need the best. The grandeur of the challenge should be appealing enough for everyone to try and chip in. And Tammam, Fursa Saida, we've never met, but we come from neighboring countries. I'm Lebanese, and good to get to know you through this. I think the first thing is it was never about COVID only in the places where we work. We work in places of active conflict and tensions and bad governance and yes, climate shocks and natural disasters that are more and more very much overlapping with conflict dynamics from the Sahel to Latin America, even in the Middle East, we see that. So the first core message that we say is that what we deal with was increased marginally by COVID, but the core problems that we deal with, such as targeted attacks and killings and bombing people and gender-based violence and youth left out without hope and all these ongoing centuries-old dynamics of conflicts, did not slow down at all during the pandemic. We had slowing down of our capacity to respond, access, but what we call protection of civilians related issues from attacks and destroying civilian infrastructure and non-respect of international law remain all over the COVID years now. We can put an S, the main problem. And that's the thing, because the major problem we deal with in areas of conflict without COVID is invisibility. Invisibility of the individuals that just dies or gets killed or gets tortured or disappeared. And this invisibility to start with is extremely hard to break. And it is an escape route for the criminals. They count on stories not being told and things not reported on to just get away with their crimes. And the major hit that COVID brought is a sole international attention on the pandemic that increased that invisibility of communities and individuals stuck in conflicts and disasters. So that was extremely hard and still is to deal with. And to be able to break that cycle of impunity that is created by this invisibility. The second thought that comes to mind is, I come from a community that lived through wars, and we know that the first responders are the families, are your neighbors and uncles and aunts and sisters and nephews and nieces. That has been well known, or much more known, for the communities living on that side of the conflict rather than on the international response. I think the recognition of the importance of local response has shot really up during the COVID years. Now, did the money follow? Was it translated to actual systemic shifts to follow that recognition? I don't know, we're not there yet, but it's not a bad trend. However, a marking thing of the COVID years is a much stronger recognition that unless you're on the ground and you have this physical proximity, you can't really respond. So relying on local responders, local communities, people themselves, is much more recognized, and that opens the door for this localization agenda that has been there. But I think there is a possible accelerating factor that came through COVID that could, if translated to a systemic change, could have a positive effect in the future. Voila.
Thank you, William. And I think you've highlighted a number of points that it wasn't about COVID alone. It was never about COVID alone in low and middle income countries. It reminds me actually of a Yemeni civil society leader and analyst who told me that Yemenis are not going to die of COVID, they're going to die of hunger. So COVID is not a priority for us as much as it is for, again, high income countries or Western nations not going through a humanitarian crisis. And that the gearing of the funds and the attention to the COVID response alone, without dealing with a lot of the infrastructure issues that they have had to grapple with, was actually a problem. So that completely resonates, and absolutely, you know, what you said about conflict-affected contexts, the conflicts have not abated at all, and now we're witnessing other potential conflicts in Ukraine, for example, and so on, that will also put a lot more pressure and will increase that invisibility factor that you've mentioned, William. Now, all of this makes sense. All of that resonates with a lot of the analysis and a lot of the voices that are out there calling for a more nuanced approach to understanding the impact of COVID in low and middle income countries. But equally, there has been a recognition that COVID has had an adverse effect also within and across society. So even high income countries, levels of access to healthcare, levels of access to even the vaccine, even vaccinations, level of misinformation, susceptibility, misinformation, disinformation has also been very perceptible across and within societies. And here I turn to Priya. You've done a lot of work on the context and the COVID response within the UK context. What lessons learned can you extrapolate from that, especially as related to questions on health equity?
Sure, thank you, Sherine. And just to say, it's great to share the panel stage with my fellow panelists. So thank you. So in terms of the UK response, I mean, you know, I'm not going to say too much about the government response at the higher level. You know, there's been an inquiry into the government response, and there's been a lot of failures and lessons learned that have been highlighted even before that inquiry was sort of instigated. And there's been sort of calls saying that we were late in introducing lockdown and social distancing measures and things like that. But what I will say in terms of my experience of co-leading a team of researchers that conduct projects across the wider topic area of health and social care is that there's a few reflections I'd like to share. The first is that we were talking about successes as well as failures. So that's something that we welcomed in the research community here was flex in the research infrastructure. So this meant that we could secure funding in a timely manner and actually go out and collect data in real time. And that was really, really important. So whether it was, you know, things like collecting data on a large scale in terms of case rates and symptoms and how symptoms are changing over time in certain groups and their vulnerabilities, that was welcome. And even kind of on a more small scale perspective, you know, we're conducting a research project on bereavement and COVID-19, the fact that people were not able to be there when they lost family members or loved ones, and were not able to connect in the normal way and follow the usual rituals and rites and attend funerals and be there for each other and be there as communities and as families. And we've been able to conduct important research around this type of thing because we were able to access funding quickly and collect data, as I say, in real time. Another thing I think is what has been positive is that we conduct research for a number of different government departments. So even though we're a health and social care policy team, we don't just do research for the National Health Service and their partners and the Department for Health. We do it for the Department for Transport, the Department for Work and Pensions, I mean, across the range of government departments, but also large charities and research councils. And one thing that was positive is this emphasis on loneliness and social connection and how that is a priority, and we need, and I'm glad that it's gone up the agenda for many, you know, policymakers. And I know prior to the pandemic, there was a lot around loneliness and older people and aging, and a lot of aging charities such as Age UK provided important befriending services and things like that for older people. But the fact that social connection is so important, not just for access to health services and essential services, but your general well-being, and the fact that you can actually be empowered and actually participate in your local community and have agency, the fact that has been recognised across the board, and I welcome that. And central to that loneliness is there's been an emphasis on digital tools and public health messaging, how that's going to become more and more important, and how digital inclusion is really important as well. But in terms of what needs to, you know, I think we missed a really important opportunity in that there have been long-standing inequalities for health in the UK, and there were calls for warnings around a pandemic for a long, long time. And these inequalities have not been sufficiently addressed, and that the evidence shows that. And what we could have done is, again, collect data. There could have been more around research priorities and funding available to conduct data on these groups that are the most vulnerable groups, minority groups, that have been lower socioeconomic groups for 2-3 generations, on why they're not engaged with the health system. Where is a lot of the reason why they're not taking up the vaccine or they're not engaged in the health system more broadly is because of mistrust. And where is that mistrust coming from? Why are these calls for public compliance and civic duty not resonating with them? And it's not just a lack of trust in the health system, but it's a lack of trust in the state more widely. And where is that coming from? And what can be done to address that? And you know, we need to connect, as I think William said, I'm sure Tammam said as well, is that this is not just a COVID-19 issue. Well before the pandemic, many of these groups were not taking up offers for routine vaccinations or, you know, calls to attend, you know, screening for cancer and routine screening and things like that. So we knew that there was that lack of engagement. And if there wasn't going to be a pandemic, these certain groups were going to be left more vulnerable. But we went, you know, there hasn't been that space to collect really important information, not just, you know, which groups are worse off and why, but what is driving that? What, you know, so I think there has been a bit of a missed opportunity there.
Awesome. Thank you, Priya. And I think Priya has pointed out an issue or a gap that cuts across both the global and the local, which is the data gap. And the data gap is one that we are facing locally within the UK, although not to the same extent to which we are facing it in conflict-affected contexts and low middle-income countries. But really, the need to understand and have enough high-quality data to drive better policy and practice in those areas. Within the humanitarian system and within the international development sector as well, there are a number of studies that have been conducted on the need for preparedness, on humanitarian responses and localization of humanitarian response in a number of crises and health crises in particular. Because I remember, as you mentioned, both Tammam and William, you both mentioned the fact that, you know, this is not new. The pandemic, there have been previous pandemics, and most recently even the Ebola response. But the question that I have, and I see Tammam also has his hand up, so I'll start off with you, Tammam. Why have we not learned much in terms of practice, right? So the thinking is there. There's a huge amount of literature that is on how the humanitarian sector and the development sectors can be better prepared in terms of the response. There's a huge literature that is also on, you know, the role of donors and the role of multilaterals in kind of engaging in that response and the importance of complementarity between international and local actors. The thinking is there, and there was a huge momentum around that. So why is it that when we talk about actual action and a better, higher quality response in practice, we are faced with a number of systemic blockages? So Tammam, over to you.
I'm afraid that we keep trying to answer questions that address the symptoms and ignore the causes. If the question is, why have we failed to prepare, the answer could be at any of the levels that say, this is a fragile system of humanitarian response. The global health governance has multiple complicated layers. WHO needs reform, and all that endlessly. The question is, why are those the situations we are in? The question is, why was the United States considered to be the best country prepared in the world for a pandemic per multiple studies? It turns out that they fell flat on their face when a pandemic came. It's not because that administration was there. It's because we are in conditions that will not allow us to have a situation otherwise. So allow me, at the risk of sounding like the voice of despair here, to attempt and go a couple of layers deeper. We're talking today about the future of solidarity. and if we decided to go and look at any definition of solidarity, it is the awareness of common identities, common interests, common fate, common whatever. There is not in today's politics an awareness or a desire for a common fate or identity or future. There's an isolation. Borders have become so entrenched that we have been seeing people die in the Mediterranean for years now. They don't even register on the news anymore. There's no common fate. We have reality TV that makes fun from people on benefit. This is not common identity or common future. So the question is, regardless to the rhetoric, the early days of the pandemic, whereby we were told that this virus is the great equalizer. Turns out it's not, obviously. But is there a possibility of solidarity in a world where all the differences have been amplified to the extent that we are seeing? Spend a half an hour watching CNN, then Fox News, and you wouldn't be very optimistic about it. But then again, a step back, 120 years ago, I think, the father of sociology, Durkheim, defined solidarity. He said that we have mechanical solidarity. The pre-civilized communities, the clans and tribes, their solidarity comes from them being small, them being similar, ethnically, culturally, or whatever. So they have no means to survive other than to have solidarity with each other. But once you civilize, once you have industrialization, and then you have what he called organic solidarity, which is from recognition of similarity among different groups of people, labor, people in different walks of life, and so on. What we've done today is, if we believe in the evolutionary element of Durkheim's view, we've brought ourselves back from the more developed solidarity that recognizes societal, economic, cultural, and so on, similarities and intersection points, into the basic, I will only have solidarity with people who look, sound, and think like me. And this is where we are in the pandemic. And the last point, if I may, is if you look at several barriers in the past 20 years. One of them is, for the first time, what was called the epidemiological transformation, 2004, I think, the burden of disease report. For the first time in human history, non-communicable diseases are more prominent, bigger cause of death than communicable diseases. We now live longer. We don't die of infections at a smaller age, at a younger age, sorry, and hence people die more of non-communicable diseases. This was celebrated. Of course, the difference is massive. Poorer people still die of infections. Even poorer people who don't die primarily of infections, if you look at country profiles one by one. Yes, in the Middle East, most people die of non-communicable disease, but they die 20 years earlier than richer people. So is there a possibility of solidarity or a possibility of a response that's egalitarian under circumstances of entire otherness? I think the answer that COVID has provided is not optimistic. We've spent months talking about respirators, ventilators, about the availability of ventilators. Ventilators on the worst of days were needed for a fraction of the patients. They wouldn't make a difference in the outcome of the pandemic as a whole, let alone that most of the non-rich world, of the global south, and of the souths in the north, as they are called by the post-colonial theorists, are not going to think about ventilators when you don't have oxygen. No, there isn't oxygen, there isn't hospitals or doctors or nurses or basic medicines for respiratory infections that still are the biggest killers of children. So I say that in the light of Sherine, what you said about COVID rates in Africa. It's willingly blind to say that there has been such cynical stuff like, what can we learn from Africa about not having a pandemic?
Yeah.
Well, if you want to have the same rates as in Africa, eliminate your health system, stop collecting statistics, and let most people die before they reach a healthcare facility. Then you'll have as low numbers. It was serious publications asking those questions. So the cynicism of the response that talked about ventilators before talking about basic care, that still allows us to have the 7th booster of some people, God knows. Now we know from Pfizer that we will need a booster every 4 months, by the way. While healthcare workers in most of the poor countries haven't gotten their first dose, is mind-boggling. So in a world of exclusion and national borders being as sacralized as they are, and where the profit of pharmaceutical companies is of a higher value of the lives of most people who would have gotten the medicines, and we will go through the whole conversation when the medicines become available. The question is, what solidarity are we talking about, and what opportunity, and what so on, and how do we not get entangled in talking about symptoms endlessly and not solving much?
Thank you, Tammam. I think you've brought up a number of issues, a number of questions there, and I think that to a certain extent I agree with you, and to another extent I would like to kind of play devil's advocate with you a little bit. I think I agree with you that it is a question of politics and economics that's really driving whether or not and to what extent the response would have been equitable. But I also think there is a systemic problem. If you still retain a level of faith in the international system, and I think we should have some faith in it, at least in its intent or its original values or original kind of objectives, then there is a question about what kind of systems are in place and to what extent those systems have been operationalized and have been able to be properly operationalized in the pandemic. And by systemic issues, more specifically, I'm asking a question about where the modalities and the mechanisms of working between, for example, multilateral organizations, donors, and governments. What kind of modalities have been in place, and could they have been operationalized in a different way? What are the existing systems and modalities internally within UN agencies, for example, within multilaterals? What level of complementarity is there between the systems within UN agencies and community health systems, which we know exist in a number of countries? And as you well know, the Ebola response is an excellent example of that, that when there was collaboration between international actors and local systems, they understood how local culture works, how local religious practices work, and managed to find an area or space of collaboration that was there was a successful response, right? So there are lessons to be learned. And there is a glimmer of hope, if you will, although I do share your frustration. I have been, even personally, deeply impacted by how terrible and how, as you said, willingly blind the response has been and continues to be. But having said that, I still think that there is a conversation to be had about the systemic issues and what can be done differently and to think concretely. And here I turn to William. Because every conversation I have with William pushes me and asks, what can you do practically, Sherine, to address this question? And if we're going to come up with a study or with analysis about, complementarity and international local response, what can and needs to change within the UN system for it to be a lot more fit for purpose? So back to you, William. What are from your perspective, and again, from the perspective of the Global Protection Cluster, what are the blockages and what can be done differently?
I think what Tammam started with in terms of root causes is and deeper problems and the symptoms is an extremely valid point and requires thinking. And I will take that from this conversation. However, I think without a doubt to my mind, but that's an emotional assessment of the situation rather than statistical. The last 2 years have shown or given a lot of impetus to the value of multi-country collaboration or multilateral collaboration or multi-agency collaboration and multi-sectors collaboration. I think that's a fact known that has been politically challenged a lot. There are still many countries that opted for very protected, isolation-driven approach response, but I think the overall trend and wave and narrative that came up from the pandemic is that one, collaboration is key, and two, lack of collaboration kills. And I think taking that argument to become a popular one, a one that anyone feels it and understands it is an important step forward. Now, can we capitalize on it and keep it on? I think it's too soon to judge. I think that is important and noteworthy. Equally important, heading towards your question, is that we speak a lot, and I am personally critical of international collaboration, lack of international solidarity, and the shortcomings. But the truth is, what we face in terms of conflict zones and natural disaster zones, it's not lack of international solidarity that killed, it's lack of national solidarity that killed. It is the lack of common faith, identity, and others that Tammam referred to that are very much clear at national level, that are creating the conflict and that are killing people, and that is more and more has seen a wave of stigmatization based on ethnicities, on religious background, on political background, on sexual preferences. This pandemic was a chance for conflicting and worrying parties and political opponents to show solidarity at national level, and they didn't. On the contrary, they used it as another layer of stigmatization and separation. And I feel the moral background and the moral upper hand of criticizing lack of international solidarity has been lost in this pandemic by lack of national solidarity in many countries. And I think we need to start thinking of it in a different way. And I don't have answers of how to take it. But I do know that lack of national and local solidarity killed more than lack of international solidarity over the last 2 years. Now, looking at the UN system.
Can I stop you there, William? Sorry about that, but I just need to probe you on that point a little bit further. Because you're making a very strong claim over here that the lack of national solidarity has killed more than the lack of international solidarity, which has led to only 8% of people in Africa, for example, get fully vaccinated. So, you know, even if there was national solidarity and there was no access to vaccines, then what good would that have done? So that's one question to you. The other question is, can you explain a little bit further what you mean by national solidarity?
Exactly. I think you're looking at solidarity from a pandemic angle. I'm looking at solidarity in a broader sense in national levels. When you have conflicts based on simple ethnic diversity or class diversity in many parts of the conflict zones today, one can go broad and claim that the root causes of national conflicts are international and there is manipulation and regional interest, etc. But what it boils down to, in some communities, that were in conflict, when COVID hits, COVID became part of the conflict, and communities started accusing each other of this ethnicity or that religious group bringing COVID to the country. And that lack of solidarity at that level of solidarity to freeze a bit the conflict and freeze a bit the internal fighting and focus on this massive external big danger that comes through the pandemic did not happen. And to me, that remained in the last 2 years. These local tensions remained the biggest killer of people. And even more, the use of COVID stigmatization against women and against ethnic groups, against religious groups, against political groups it's an equally big shock to that of 8% of Africa is vaccinated.
Okay, thank you for clarifying that, because I think I agree with you that, you know, dealing with the pandemic in a conflict-affected context is a completely different, requires different calculus altogether. And there have been definitely instances in which the pandemic was weaponized by conflict actors on the ground. And that surely has had an impact in terms of loss of lives and also loss of livelihoods, and trying to win territory and win an edge in the war. But still, you know, going back to some of the systemic issues and what you mean by, you know, national level lack of solidarity, I get that, I understand that. But there are other countries where there was some level of solidarity, and it was the lack of solidarity between international and national that was the issue. And here I'm referring particularly to a number of studies that were conducted, a number of studies that actually I was part of, and where overwhelmingly my respondents would say there's very limited communication between headquarters level, for example, at UN agencies, and field level. And that lack of communication basically means that a lot of the policies that are coming top down have very limited reflection or understanding of what the local political dynamics or political economy dynamics are. So surely that is a level of systemic change that can and should be addressed. Do you have any thoughts on that?
Yeah, absolutely. I think you're totally right. I think the pandemic has served as an accelerator of the thinking that the age of mandated agencies as the only criteria for defining policies and leading on the ground is gone. Now, how long will it take to actually materialize and become a new system is another matter. What we see on the ground today is that leading on protection response, like leading on COVID response, is a matter of truth and frontline proximity. You need to be there on the ground. And we have to remember the last decade of humanitarian aid and conflict zones has been one that is tending more towards bunkerization than towards being there on the ground in the villages and the camps and the front lines. And I think the 2 years of COVID has extremely shifted that bunkerization tendency to an extreme where we see many of the international organizations really not present on the ground. Now, there are few actors that are, and I pay utmost respect for them, but the tendency is bad. And I think it is extremely important to bring back to the international organizations the extreme importance of being present on the ground while recognizing that response is led by local actors. Response being led by local actors shouldn't be a shield for international organization to avoid being present and say, we have partners doing this and doing that. When it comes to protection issues, to gender-based violence, to child recruitment, for soldier purposes, for trafficking of girls and women and young people on the ground. You gotta be there as an international organization to see, tell, and react. And yes, the actual response might have to be led by local actors who know the culture and are able to operate, but that extreme importance of being there to see and tell and react, we need to reverse the trend. The trend is very bad, and we have very few years of avoiding that there is a cultural shift where we just become headquarters only and not with boots on the ground. So looking at the system, I think we need to shift away from mandates logic to leadership on the ground that is coordinated operationally on the ground. And that will be different from country to country. That will be different from operation to operation. And the biggest challenge will be, how do you maintain standards of quality of the response in such a context? And I think that's our big next big challenge of a humanitarian response. How do you actually fully localize and contextualize while maintaining standards of quality from a technical perspective? As localization will enable your operationality and cultural sensitivity, you need to top it up with this layer that is not so hard to crack in theory, but we have to keep an eye on it.
Thank you, William. And now I turn to Priya. And Priya, you've done a lot of work on health systems and systemic problems and how to address them in a sustainable way. So what is your take on the systemic blockages in the COVID response within the UK context, and what are your reflections on that?
Yeah, no, so I mean, it definitely did put, the pandemic definitely did put a lot of pressure on the system, on the health system and the social care system. It laid a lot of issues to bear, long-standing issues around the lack of workforce management, lack of funding. One thing, a couple of reflections really. First thing I'd like to say is I've done some work on multi-morbidity and healthcare intelligence, and it's very clear that the UK system was built around dealing with one condition at a time. And, you know, the COVID-19 showed that people with comorbidities, multi-morbidity, were more at risk in terms of of having the virus in the first place, but then in terms of a recovery and long COVID. And when you're working with a healthcare system that was designed to deal with one condition at a time, it puts a lot of pressure on patients and service users in terms of them being able to manage their illness and manage their health. And just COVID-19 made it a lot worse. And so there have been calls for better digital infrastructure, but it's very difficult when we're so entrenched in working in this way of just one condition at a time, one discipline, one healthcare practitioner at a time. So we need to be able to deal with multi-morbidity in a much better way than we do at the moment. And that's one thing that we are hoping to do at NatCen International in terms of trying to build a global health policy programme and support researchers and policymakers in other parts of the world who are a little bit earlier on in their journey of building a health system and a healthcare infrastructure, so that they can actually not make the same mistakes we did in terms of being able to support people with not just single conditions but multiple conditions. In terms of things that may help us moving forward, so there's been a move towards integrated care systems in the UK, and we've actually had decades of actually working under a system where there was a focus on competition in terms of it. In fact, it was encouraged, and there were traditional boundaries in place in terms of commissioners and clinicians and other healthcare practitioners, and boundaries between physical and mental health and local authorities and the NHS and their partners. Whereas integrated care systems, I don't think that they were brought in purely as a response to the COVID-19 pandemic, but they have been brought in and they're being introduced now at this stage. And it could potentially be a positive move because it's about removing some of those boundaries, those traditional boundaries between disciplines, removing boundaries between physical and mental health, a lot more of a coordinated response in terms of removing traditional fragmentation and integrating health and social care services and promoting innovation. William was talking about national solidarity, and that made me think of regional inequality here in the UK. And there's going to be more of an emphasis on networks of hospitals that are doing well on certain indicators, supporting those that are more poor performing and helping them implement better models of best practice in a way that they can actually serve their underserved and hard to reach communities. So that could be a move in the right direction in the UK, but wait and see.
Thank you, Priya. And I think that broadly speaking, what I'm getting from the conversation so far is that there are definitely the contextual issues that we've been grappling with within the humanitarian system for a very long time, the political economy issues, the political will, the lack of capacity to effectively and properly cede power from the international system to local actors, all of those issues. But there's also the issue where actually reforming and building health infrastructure and health systems and the capacity to think about opportunities for cross-fertilization and learning that can be made possible, and where the pandemic can actually be a starting point for some new thinking in that area. I mean, I remember Obama's healthcare, health security plan years ago, and a number of other initiatives that tried to put forward that question of health security, which at its heart is really a question about health equity. It is about ensuring high quality healthcare for all, regardless of ethnicity, socioeconomic background, level of vulnerability, sexual orientation, what have you, right? And so I think there is definitely an opportunity there for some form of new thinking and mobilization to take place. And I'm hoping that this conversation and other conversations that we have with a number of partners can help really further that agenda. So now at the end of this discussion, and before I open to the floor to questions, I want to ask you all to look forward. What are the 2 or 3 lessons that you've taken from the last couple of years that you would like to take forward and that you would like to see changed? And I give you the freedom to identify which problem of all the problems that we've mentioned so far takes precedence above everything else for you. So Tammam, I'll start off with you. What are the 3, if you can come up with 2 or 3 key lessons that you've learned from the past couple of years that you would like to see changed? And try not to be, I know that you said the voice of despair, but if you were really to see any hope in that, what are those 2 or 3 things?
Yes, and by the way, being the voice of despair doesn't preclude hope. In reality, it eliminates the ability for false hope, for fake reform, for semantics, for small stuff to be claimed as big reforms for the future that end up being thrown down the road as real hope, only to be hit with the next wall that we are going to face. And I do not lack belief in a multilateral system. I lack belief in the current multilateral system that we've inherited from the winners of a world war. But the multilateral system came at the time with Keynesian economics that allowed for care for the poorest in society. This has been dumped by Thatcher and Reagan and the neoliberals, and we are left only with a governance by the powerful. The oligarchy today of the global multilateral system translates into an oligarchy in the global health system. There are people who meet in meeting rooms in Geneva and decide who gets vaccinated or not. Meeting rooms in New York and in Washington, DC, those are the biggest concentrations. The problem is not that there's too much headquarters. The problem is that the headquarters are focused and implanted into a way of seeing the world that only allows for, Global Health 50/50 had done their research on gender equity in global health. And the last one has found what they call the 70, 80, 90, 70% of CEOs and leaders in global health organizations are white men, 80% are from the global north, and 90% are educated in the global north. One of the opportunities for the future is to dump this single, unifocal view of the world that only allows the rest of the world to be successful if it manages to mimic the West. Now that we've found that the West hasn't really done much better when there is a massive emergency. Let's face it, COVID is horrendous, but it's not worse than the Indian Ocean tsunami or the earthquake in Haiti or the civil war in Yemen or Syria or Libya. So having been denigrated for not being able to respond well to all those emergencies, and I'm not going to talk about the origins of those emergencies and the grounds that allowed them to happen. We have realized that we're all in the same ship of incompetence and inability to organize in the face of the, grand events of nature and history. A good lesson for the future is recognizing that and starting to concede that maybe there are other ways of doing things that work, and letting that allow us to govern global health, not by a technocratic, means of quality is only quality if a hospital in you name a country of the global south looks like a Norwegian or a Swiss or an NHS hospital. Quality is quality when people are satisfied and convinced and capable of utilizing health and capable of getting what they need for them from their point of view. So that's the first step for the future. We realized that, at least under the current political circumstances, equality in resources is not on the books. As long as we have countries, as long as the predominant sentiment is we protect ourselves first before we go and care for others, as long as others are perceived as fundamentally different and less deserving, then at least let's allow those others to conceive their part in an egalitarian multilateral system, whereby their only recourse is breaking the system. Chile, for example, was one of the first countries in the global south to vaccinate widely. And they only did that by discarding Act A and the global mechanism for vaccine. Their skepticism of the multilateral system turned out to be their ability to vaccinate. So one of the things is recognizing the weaknesses beyond the symptoms and having a conversation that doesn't just talk about reforming financing of WHO or reforming, or having a treaty about the pandemic, all of which will be good and are needed. But we need to go beyond that into talking about, okay, we're all vulnerable. And Western biomedical model that is implemented by oligarchical technocrats isn't solving the problem as we've seen the past 2 years. So what would solve it? And here, we'd better learn from people who have been marginalized in the global health conversation, from indigenous communities, from people on the margins, from people who had to make do with failing health systems. Those will tell you how to function in a crisis. We in the West, medicine has become a technical discipline. In the Middle East, we used to call Dr. Hakim. Hakim means a wise person. And a wise person because they were assumed that their education and exposure allows them to see the world from a wider angle. Now we have reduced our medics into technical, capable of reading tests and imagery and, prescribing particular medicines. Biomedicine needs to be a part of a social movement that seeks justice not only for sick people, but for people who are marginalized otherwise, and that interacts with global, with other justice movements. So that is an optimistic thing. That is a hope for the future. And in practical terms, holding accountable the global systems that haven't functioned well is necessary. There are UN agencies and global organizations and governments of the West who have, by their actions, caused harms to other and benefit to other, who aren't going to pay for it. And the only accountability they fear is the electoral accountability. So starting to talk about that widely, allowing for the intersection of health, humanitarian, and other justice movements, and learning from people who have for centuries been making do with less than perfect conditions, like people who have been in exploited and marginalized communities and indigenous communities, listening to them not just as informants, but as teachers and as people who have as much wisdom, might be a very good place to start for us to tackle what a governance of global health, which is absolutely needed. We need to be able to work together, might be a good step. And potentially less of, white boots on the ground. Or, I'm not undermining the exchange of experiences and knowledge. But so far, the humanitarian boots on the ground have been boots of people who are coming to tell others what to do. A change of that would be another good step forward. The last thing I want to say is the technical capacity. Absolutely. We need technically sound science. Once we acknowledge that health is not the product of evidence-based biomedicine, it is the way evidence-based biomedicine is possible to implement in social and political context. And oftentimes hiding behind biomedical evidence alone ignores the social and political and economic aspects of that biomedicine and allows for discriminations to continue. So yes, technical sensibilities and standards of quality should just be expanded beyond the name of the medicine or the name of the vaccine, and where and how and who and to whom is it being given.
Thank you, Tammam. I think you've really steered the conversation in an important direction, and I think we've been kind of edging our way towards it, which is really to go beyond the biomedical and really start thinking from the perspective of local or indigenous actors and how to bring local, international, everything in between together for a process of mutual learning, and where there is a recognition of some level of equity in terms of power and equity in terms of decision making and so on and so forth. I turn to William. What are your 3 lessons learned, and what are the 3 points that you'd like to take forward?
We seem to have lost his connection.
Oh no!
Sorry. Yeah, we've been trying to get him back.
Okay, we've lost William's connection, unfortunately, but hopefully we'll be able to get him back. Priya, over to you then. What have you learned from all the research that you've done on health systems and equity and minority groups access and so on that you think we should be taking forward?
Okay, so there's a few things. First of all, I think we need to come back to our commitment towards equality and why it's important, not just because it's the right thing to do, but because research shows, the evidence shows. There's a great book written called The Spirit Level, which shows that equal societies with a smaller gap between rich and poor, are happier societies. And that's in terms of a range of physical and mental health conditions, depression, anxiety, but even in terms of violence and criminal activity. So we need to come back to that commitment and make that commitment a little bit more strongly. Secondly, I was talking about mistrust earlier. If now is the time for us to break down these barriers of mistrust and really understand why certain subgroups and communities do not have trust in the health system or the states. Where is this mistrust coming from, and what can be done to address it? So we need to build long-term partnerships. Tammam sort of said it's not about incremental change, it's about big steps. So we need to make long-term partnerships with these communities and to really understand how that trust can be gained and what they want to be able to have that trust. And from a research perspective, I would like to see more funding and more of this in terms of research priorities, because every invitation to tender that I receive on these types of communities and these types of challenges are on a very short time frame and with not enough money to do that research properly. And also, we're not able to do dissemination properly. We're not able to go back to these communities we've collected data from to actually close the loop and talk to them about what we've done with their research. And they're already facing research burden and not wanting to participate in these projects anyway. So we need to facilitate that, longitudinal projects, proper fully funded research projects on these communities to understand where this mistrust is coming from and how it can be addressed. The other thing is we need to help them understand the system. I've done research around satisfaction with social care services and why certain groups have lower levels of satisfaction. These communities don't understand what social care is. They're coming from countries, or their parents or grandparents came from countries where there wasn't really a welfare system. And social care cannot easily be translated into different languages. So asking them why they're not happy with a very specific service that they've been that is available to them when they don't understand the wider welfare system, where they sit in it, what their rights are, is a bit irrelevant. So we need to help these communities understand the system and communicate with them more effectively beyond just translated information, leaflets, and those types of things. And so we need to work with these groups and grassroots communities to make that change. And finally, I just want to talk about the second and third generation. So explain that global health and transnational care is not just something that's happening over there in different countries. It does affect a lot of families and communities here in the UK. So not just migrants, first generation migrants who've come over and left parents or other relatives and family behind in their countries of origin, but many second and third generation UK-born minority groups are going for onward migration, for lifestyle and economic opportunities, and they're leaving their elders behind, who already are worse off in terms of employment and earnings and health status, but then their support network in terms of their UK-born children and grandchildren are also leaving them, so they could be even more vulnerable. And these communities are aging in place, and those who are not going on for onward migration, who are staying on, who are second and third generation migrants, as I said, translated information sheets is not enough. Talking about how traditional cuisine is going to make you more susceptible to diabetes or hypertension is not going to connect with these communities. We need to connect with the next generation. These are cultures in transition. We need to appreciate that and speak to their specific challenges and the difficulties that are part of their lived realities.
Thank you, Priya. And now, before we close, I would like to just take some questions from the audience or from online. Are there any questions here?
There is one online.
Oh dear, I can't use my eyesight.
Okay. So Sabrina is saying that the BBC has just run an article about making a documentary about the potential reality of the Oxford AstraZeneca vaccine and how it's supposed to be a vaccine for the world, but then the UK didn't give it away quickly enough, and how it's been discredited by other global governments. Does anyone have any thoughts on the impact of this?
Okay, shall we start with Sabrina's question first and then move over here if there are any questions? I've got questions of my own and then close. So Priya's question about AstraZeneca and the fact that it's getting discredited globally. Are there any kind of comments or suggestions on what can be done on that front?
Honestly, I think Tammam probably has more to say and more experience about this than I do. But from where I'm sitting, it seems there seems to be a lot of politics around vaccine development, a lot around the vaccine race, and countries, we will only accept this vaccine if you want to come into our country. And there was this hierarchy of vaccines, and I don't think that was just based on scientific evidence. I think there was more to it than that. But I think Tammam probably got more substantial sort of response to that question than me.
Any thoughts then, AstraZeneca?
Thank you, Priya. I think, look, there are a couple of issues. First, AstraZeneca's Oxford vaccine is a massively successful scientific and intended experiment until it was given up to AstraZeneca and they were allowed to, their commercial interests were allowed to intervene. Now, to their credit, the license for the vaccine was given to the Serum Institute of India, which is the biggest capacity of manufacturing vaccines in the world. And many of the people who get AstraZeneca now, Oxford AstraZeneca vaccine, get it manufactured in India. And this is more than any others have allowed to happen, like the other vaccines, the Pfizer and Moderna and so on. The point that Priya talks about in terms of there's more politics than to the validity of vaccines, of course there is. Oxford vaccine was supposed to be license-free, and it wasn't afterwards. But there's also the government's positions across Europe and in the North of restricting or not allowing, the market for vaccines was controlled quite rigidly in the early days of vaccination, out of panic. You'll remember the news about the anger matches between Europe and the UK about supply of vaccines. There has been multiple cases of restricting exportation of the vaccines, and so on and so on. But in the end of the day, we are led to think that the vaccines are better or worse according to the advertisers. So I would wager that if you ask many people, they'll tell you, oh, probably the Pfizer and Moderna vaccines are better than the Oxford, and definitely wouldn't want to get vaccinated with the Chinese, with Sinovac or the Russian vaccines. That's politics. There's no evidence I know of long-term effectiveness that is different. And if anything, as I mentioned, the Pfizer vaccine, yet again, is fizzling down in immunity and so on. So we don't know. We are affected by the politics and perceptions of what vaccines are better or not. That adds to the fact that vaccination for COVID is a many multi-billion-dollar industry now. Pfizer will have made more money than a medium country in the past year out of selling vaccines. And that is going to be protected viciously by everybody who has a stake in it. So to say the truth, I think the Oxford experiment started with great intentions, as I understand it. There has been a difficulty when there is a public entity like the University of Oxford and the AstraZeneca as a private pharmaceutical company. Still, the ability to distribute it through the Serum Institute of India, despite some snags, because the Serum Institute wasn't always transparent about the vaccine pricing as well, and sometimes sold it for more than what Oxford AstraZeneca were selling it to poorer countries, is still probably one of the most worthwhile ways of looking at vaccine development under the circumstances we have. At least, unlike the other vaccines, the taxpayers didn't pay for it, didn't do a down payment for the research and paid full price for the product afterwards. I'll just say one thing here. I mean, vaccine is one product of many, and the vaccine equity is going to be important. There has been an excuse of not sharing vaccine technology, of there's no capacity to make messenger RNA vaccines like the Pfizer and Moderna one, which is a false claim. MSF proved it by a report that found that more than 120 sites globally that are capable of manufacturing mRNA vaccine, but also the lack of emphasis on the behavior towards vaccine in rich countries. There has been now a rush to distribute nearly expired vaccines that have been over-ordered by rich countries. And people were struggling to understand, why would poorer countries reject vaccine donations like that? Because they don't have the capacity to distribute nearly expired vaccines. And because this shouldn't be the way of global solidarity, of massively over-ordering vaccines, keeping them in warehouses until they're nearly expired, and instead of throwing them away, shipping them, into places that doesn't have the capacity, ends up, by the way, with the cost of destroying them because it's expensive to dispose of medical supplies. So there are absolutely lessons to learn from how vaccination has been handled, and not only the intellectual property, but the commerce protectionism of the suddenly no one believes in the market anymore, and everybody is circumventing it for their own interest.
Thank you, Tammam. And I think that we are approaching the end of the session, but I see Guy has a question. So
it's not a question, rather more than a comment. And I wondered whether the panel would just comment briefly on it. I mean, one of my observations from the UK perspective is actually I've been surprised by how powerful and how much influence the health professionals and the scientists and the so-called SAGE PM committee have actually had. And that partly links into Priya's comment about trust. There's quite a high level of trust among the public in those groups in the UK. But I wonder whether that also is a source of hope, in the sense that I think it's rather easy, isn't it, to blame national politicians who, as Tammam says, will always look to their electorates and always come across as a bit of a pain, but they're playing to an audience, aren't they? And yet, to a degree, the UK government and the devolved governments in the UK have had to listen, largely, not entirely, but largely through this pandemic, to the scientists and to the health professionals. And if you were looking at it rather than at a global rather than individual country level, the sorts of things that nationally people have looked at, the demography, the health conditions, the risk of catching COVID, mainly in developed countries, things like the mobility and whether you're on the front line and those things, not so much poverty, because which of course is relevant here, but you can't do much about quickly, you could argue. I wonder whether, internationally and globally, cannot the equivalent expertise and experts talking together have as much effect as we have seen in some of the developed countries, but from across a more global community?
I think that's a very good question, actually. And I think it's a question, I would have an answer for that, but I think I would defer. I would not exploit my own rights as chair over here, and I would defer to Tammam. In the countries that you've worked in, and I think it varies from one regime to another, and one government and one context to another, to what extent has there been more trust in the scientific community, or a build-up of trust between the scientific community or scientists in general and government and society? Do you have any reflections on that question?
Thank you. There are a couple of elements here. Of course, trust varies greatly from one place to the other and from one context to the other. And some governments obviously have earned less trust than others. There's a couple of fundamental differences. There is a trust in the UK scientific community because in my sense of trust in richer countries is because there is an acknowledged capacity to do biomedical science that leads to evidence-based results. In the absence of capacity for scientific research in many poorer countries, what is left is the use of evidence generated in richer countries. That has one of two problems, two problems. If you don't trust the richer countries politically, it's difficult to trust science because science and politics are intertwined. And secondly, most of the evidence that is generated for contexts where you have health systems. So the evidence and science that is generated in the US or UK or Western Europe is generated to address the problems and deficiencies in those places. And they aren't fit necessarily for places that have poor. So there is a direction now towards like the Africa CDC, for example, is becoming a prominent force about establishing health sciences, public health and health governance in Africa. And I would heartily hope that they will be able to continue what they are doing and do it with the independence they deserve to have in viewing that. The second point is, Priya mentioned about trust and about understanding the system. So, you said, Priya, I don't want to paraphrase you. You said how trust can be gained. And I would say how trust can be earned. Because no one deserves the trust of people who are dying of disease. If people have been dying of HIV, of malaria, and MSF, when I worked there in Doctors Without Borders, until now, 1 in 4 patients is a malaria patient, still hyperendemic, easy and cheap to diagnose and treat. If people have been dying of tuberculosis, of maternal mortality, of sepsis at childhood, all of them are problems with simple solutions that haven't been solved. Why would they trust that the upcoming solutions for the new problems would be better or more efficient? Trust needs to be gained. The difference, in my estimate, that's not my words, there's an argument about paternalism. Health systems are paternalistic by nature. The difference is, in a Western setting, in a liberal democracy, there's at least the illusion of recourse to accountability by elections. If the government messes up something, causes people to die, you can, vote against them. In international politics, people who are sick or who are affected by crisis do not have a similar recourse. So the skepticism is justified because people whose lives are being decided by others do not have a way of holding those others accountable. And the last point is help communities understand the system. That might be valid for the UK. In a global setting where the system hasn't been, capable of doing its best, let's say, help people change the system. Understanding a defective system isn't enough. People need to change it. And by people, I don't mean national governments, because the argument about the coloniality, the continuing coloniality of the West is equally equivalent for the continuing colonial, inheritance of what some of the researchers have called colonialities in the South, which is the governments of countries of the South. All of them are equally unaccountable towards the lives of people, the poor in subaltern, in poorer countries. So people don't need to understand the system. People need to have a way to change the system. And so far, that hasn't been possible in global health or humanitarianism, because in the best cases, we go and ask them questions and then have the liberty of either do or not do what they tell us. And that is fundamentally the localization, is the ability to allow people to make choices, fundamental, that changes the system, not just tell us what intervention to change or do better or more of or less of. That's accountability. That's to some extent available to patients and communities in the UK and is not at all available to people in poorer countries.
Thank you so much, Tammam. I think that that point on localization and the lack of communication, lack of community engagement, and the existence of proper tools for them to be able to communicate exactly what they want and how they want it. I think that is a problem for the humanitarian system, but it's also a problem across a number of other contexts to varying degrees. And I think that question of trust and what impact has COVID had on trust in societies that are not northern societies in the global south. I think there are some good examples. I think Jordan, for example, would be one case study look at and to examine a bit more carefully. And another context which seemed to have been, have had some form of success and some form of trust in government as a result of the way the government handled the COVID pandemic. But I think that's a slightly different question from the scientific community, although they're all intertwined with one another, as you mentioned. Now, William, you've joined us, and we have to close because I realize this is the end of the session. So I'll give you the floor for a couple of minutes to respond to the question that you weren't here to respond to, which is, what are the 2 or 3 lessons learned from your experience with the pandemic that you want to take forward? Has the pandemic at all changed your vision for the global protection cluster? Or has it confirmed your vision?
Thanks, and apologies for missing part of it. I think I did intend to fly in and be there in person, and voila, this is what we have to deal with. The one most important thing that the pandemic has confirmed is that humanitarian action has to be on the ground, in the villages, in the towns, in the camps, where people are. And we have gone far too much in an opposite direction to that. We need to bring back, from a protection perspective and a human rights perspective, the importance of courage in a humanitarian action and presence on the ground. And that will require a mind shift of what success looks like and how do we measure our work as international organizations. How do we measure our work as national organizations? So for us as a global protection cluster, we have worked over the last 2-3 years on influencing all the other humanitarian sector, from distributing medical services to shelter to water, to have a human rights mindset in the way that is being conducted. And we will keep pushing on that, because I think that's a confirmation that the pandemic, without a rights approach, wouldn't be equitable and wouldn't really deliver, but would do harm. But the second thing, which is our quest for the next period, is today we have 150 million people in the world that have need of international protection. 150 million. We have the increase from last year to this year is actually around 40 million. That's the biggest jump from year to year. 40 million people more need this year international protection than last year. And that's because of old stubborn conflicts and new conflicts. Today, we can only reach marginally 20% of these 150 million in a comfortable way, to be able to say that some aspects of protecting them or enabling them to protect each other better is happening. 20% only. And that's the whole international humanitarian system. We can't earn the trust that Tammam has been talking about. We can't continue having the legitimacy with such level of access to where the problems are. We need to change that. And I think unless we have a different way of looking at risks that we take, a different way of looking at priorities, and a different way of working outside our offices and headquarters, we won't be able to do that. And this is where local response should fill part of the gap, but we shouldn't hide behind local response only and keep the pressure on the international system to be present on the ground. And that's my final contribution for today.
Thank you so much, William. I think you've summed up very nicely the whole really discussion, that there is a need for action both at the international level but also at the national level, and that if we're really going to be putting together a compelling and a reframing global health agenda that focuses on ensuring health security and health equity, it has to happen on both fronts. And that it has to happen also with a lot of, I think, a lot of bravery and honest conversations about the issues and the blockages that are there. So just to sum up the conversation we had today, and I would like to thank everybody that has attended today and attended online. We've addressed a number of issues, the multi-leveled risks and challenges that have resulted both from the COVID response, but have also accompanied the COVID pandemic. We've also addressed the need for local action and the problems and the blockages that are there to having to a proper localized response. We've addressed issues related to existing systems, both locally within the United Kingdom, but also internationally within the UN system. And also we've addressed questions related to governments and the level of trust or mistrust or distrust with the scientific community. And I'm hoping that this would be a beginning of a conversation, not an end to it. So I'd like to thank you all in attendance and also thank Keble College for the opportunity to have this conversation, to start putting together an action agenda, if you will, to take this forward. I'd also like to thank NatCen for co-organizing this discussion. I'm really looking forward to taking this conversation with you all in upcoming months and through our new program of international social research, where we are hoping to bring those worlds and those conversations together in the international and at the local level. So thank you so much, and a big thank you, of course, to the speakers, to Tammam and William, who wanted to be with us today but could not make it. I'm hoping there'll be an opportunity for you to come at some point, for us all to get together and have a follow-up conversation on this. And a big thank you to my colleague Priya, who's really been working tirelessly with me and with others across the organization to think very carefully about what a global health agenda would look like, drawing on expertise from the UK and opportunities for replicating it and expanding it internationally, but also with other people like Tammam and others, where we are actively keen on taking that agenda forward. So thank you all, and I hope to see you soon. And please do keep in touch and keep following up the news from NatCen International.